This video is going to be super interesting, I promise. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to look at gonorrhea. I thought it was very important that since we covered urinary tract infections in the previous video, that we will use this video to piggyback off and learn the concepts of sexually transmitted infections, beginning with gonorrhea. In view of the new style of my videos on the channel, I start off with a warm-up question that I want you to answer. Scream the answer at your screen, write it down somewhere. I will give you the answer at the end of the lecture. So what exactly is the single best answer? Pelvic inflammatory disease, PID, is a term used to describe infection in a pregnant woman in first and second trimester. B, can be sexually transmitted. C, is not common in young women. D, has no bearing on fertility. Write down your answer. I will give you the answer at the end of the lecture. Before I actually dive into gonorrhea, I first want to give you a little bit about some facts and myths that arise from gonorrhea. Myth number one is that most people blame gonorrhea on public toilets, that you can catch gonorrhea from public toilets. That's a myth. So the bacteria that causes gonorrhea actually does not live outside the body for a very long time. So for this reason, we can't develop the infection from just using a public toilet. The second myth is that oral sex does not spread gonorrhea, or you can't get gonorrhea from just doing oral sex. That is false. Vaginal sex is the most common way gonorrhea is spread, but the infection also can be gotten through oral sex. And it's because of these reasons that you must strive to protect yourself and your partner, because these sexually transmitted infections can actually go and be transmitted through oral sex. So you should use dental dams and other methods of protecting yourself from contracting these, like, for example, the use of condoms during vaginal and anal sex, in addition to abstaining even from oral sex. Then the third myth is that you can tell when someone has gonorrhea. This one is ridiculous. The only way to actually tell is to examine the patient and to order for certain investigations that we'll talk about, what we call an STD testing. And that's the only way that we can actually tell, because some people may actually walk around and they don't have any symptoms and they may actually have gonorrhea, so they may be asymptomatic. So in some cases, there is an unusual vaginal discharge. Others may have specific types of symptoms that may suggest that they may have gonorrhea, but just looking, you can't really tell that someone has gonorrhea. You'd have to examine them fully and get a full history, as well as order for certain investigations. Then the fourth myth is gonorrhea testing is too complicated. So the testing isn't complicated at all. All we just do is collect some samples, send them on a special type of media. Then, of course, these samples are coming from the cervix, they're coming from the urethra, and we can look at these under the microscope, and this can help us make a diagnosis. And remember that the earlier you get the diagnosis, the better the treatment is going to be, and the better the response, as opposed to waiting until complications set in. Then the last one is gonorrhea isn't treatable. So we can actually treat gonorrhea with courses of antibiotics, and with effective treatment, we can actually cure gonorrhea. So these are just some of the common myths and facts concerning gonorrhea. So before I actually jump into looking at gonorrhea, let's just first look at an overview of sexually transmitted infections. Now remember that these were also referred to as sexually transmitted diseases, but we rather now clearly refer to them as sexually transmitted infections. They are caused by a number of microorganisms that cause a wide range of symptoms. They have a wide range of diseases, different life cycles, different sizes, and different susceptibility to the available treatments. Now, because most of these are going to be contracted through sexual activity, close contact with the skin, mucous membranes of the genitals, the mouth, and the rectum, many of these organisms are actually efficiently spread between different individuals. And some of the STIs can actually cause inflammation, like gonorrhea and chlamydia. Others can cause ulceration, like herpes simplex, syphilis, as well as chancroid, while others actually do predispose you to HIV infections, especially the ones that cause ulceration. I talked about that during HIV week. Then, of course, remember that the STI prevalence rates actually remain high in the world. Despite the improvement in diagnostic and therapeutic measures, patients still have STIs and they are not getting treated, and some of them come in with complications. What are some of the causes of sexually transmitted infections? So we may have bacterial, we may have viral, we may have parasitic. Typically, most of the cases are going to be attributed to bacterial causes. So you have syphilis, gonorrhea, chancroid, lymphogranuloma venereum, granuloma inguinale, chlamydia, mycoplasma, and ureaplasma infections. Then viral STIs include genital as well as anal warts, genital herpes, molluscum contagiosum, HIV infection. Parasitic infections that can be transmitted sexually. These are not typically what we refer to as sexually transmitted infections, but they can be transmitted sexually because of the close contact. Trichomoniasis, which is a protozoa, scabies, which is caused by mites, and pedunculosis pubis, which is caused by lice. And of course, remember that there are some infections that are not primarily sexually transmitted infections, but they can be transmitted sexually. I'm not saying that these are sexually transmitted infections. I'm saying they can be transmitted sexually. Salmonellosis, shigellosis, campylobacteriosis, amoebiasis, giardiasis, hepatitis A, B, and C, the Zika virus, cytomegalovirus. These can be transmitted sexually, but they are, strictly speaking, not really sexually transmitted infections. Now, what are some of the factors that are impeding the control of these sexually transmitted infections? Number one, unprotected sexual activity with multiple sexual partners. This is a very big thing where people are just sleeping with anyone and they're not really protecting themselves. Then, of course, there is a difficulty talking about sexual issues for both physicians and patients. You often get this interaction that is very awkward between a physician and a patient. And I do understand, given the age difference, now we get physicians that are quite young or doctors that are quite young. Imagine this, you're in a scenario where you get a young doctor that's dealing with a significantly older patient, and it's very awkward to talk about these sexual issues. Trust me, I've experienced this. From experience in talking to different patients, it's very difficult and very awkward to talk about these issues, but you have to find a way to talk about them and break the ice. Then, of course, there is inadequate funding for implementation of existing diagnostic tests and treatment, as well as development of new tests and new treatment strategies. There is also susceptibility to reinfection, especially if the patients are not treated with their partners simultaneously, because they'll still keep getting the infection from the partner. Individuals are also not compliant to the treatment, or sometimes they may not receive the complete treatment, and this may lead to drug resistance organisms. Then, of course, international travel can facilitate rapid global dissemination of the STIs. These are some of the factors that are impeding the control of sexually transmitted infections. How do we make a diagnosis? So often it's clinical based on our symptoms, but we may do a gram staining and a culture. That's your microscopy, culture, sensitivity, or microscopy culture and sensitivity. Then you may also order for other laboratory tests. We can order for what is known as a nucleic acid amplification test. And remember that these diagnostic tests are often done in certain scenarios. For example, when you're not so clear about the diagnosis, when the infection is severe, or when the initial treatment is ineffective, or maybe other reasons. It could be due to public health surveillance, it could be psychosocial reasons, it could be even in extreme mental distress or depression. And these are going to be some of the indications where we would have to do this special type of test, which is a nucleic acid amplification test. It checks for nucleic acid. So it's actually much more sensitive than the other tests that we have. Then how do we treat these sexually transmitted infections? So there is an approach which is known as a syndromic management. This is very important, especially in areas where the resources are limited in third world countries. So remember that sometimes you may not have the diagnostic test available, and even if you have them, collecting the sample and transporting it to the lab requires certain incidences, certain measures to take in, because it's very difficult to culture some of these organisms. So in this way, you also have patients that are very difficult and you're not so sure that this patient will ever come back if they leave your office that time. That's how we can offer them syndromic management. Think of it like this. Suppose you're blindfolded and they tell you that an enemy is coming and 10 people are coming and you have a bazooka. You would shoot and this bazooka would destroy everything. So this is what we're doing. We're giving a medication that is targeted towards what we think is likely causing these presenting symptoms, whether this patient is presenting with a urethritis, a cervicitis, genital ulcers, pelvic inflammatory disease. So most of the sexually transmitted infections can effectively be treated with drugs, but resistance becomes a very, very big problem. Then, of course, you have some antimicrobials that we will talk about. Then simultaneous treatment of sexual partners is very, very important. You can't just treat one patient. You have to treat both of them. I'll tell you about the different strategies in which we can treat both patients, because sometimes it's very difficult to actually get them in the room, especially if you have discordant couples and especially if you have a married person and let's say the girlfriend on the side comes into your office, then it makes it a little awkward to call the husband and the husband has to call the wife with the contact tracing and all that. But of course, that is mandatory that you must do that to prevent the spread of sexually transmitted infections. Now, remember that patients who are being treated for bacterial sexually transmitted infections must abstain from sexual intercourse until they have completely eliminated the infection from them and their partner. And of course, their partner should also be evaluated and they should be treated simultaneously. Now, with the viral sexually transmitted infections, such as herpes and HIV infections, these ones usually persist for life. So once you get them, you have it for life. And you may actually use some antiviral drugs that can control it, but cures have not yet been found up to date. We only control these things. Now, how do we prevent and control sexually transmitted infections? So we require adequate facilities and trained personnel for the diagnosis and treatment. Of course, there are some public health programs that are instituted to locate and even treat any recent sex partners of the patients. Then, of course, we should follow up all the patients that have been treated to ensure that they are cured, educate the public about sexually transmitted infections, how to prevent them, and of course, avoidance of high risky behaviors by patients, sleeping with multiple partners unprotected, and of course, unprotected sexual intercourse to begin with. Then, of course, condoms and vaginal dams, if they're used correctly, can greatly decrease the risk of some sexually transmitted infections. And note that I am emphasizing on greatly reducing, not really completely eliminating, because these measures do fail at a certain point. The best way to actually prevent any sexually transmitted infection is to not have sexual intercourse in the first place. So that's like the 100% fail-proof evidence that is there. Then, of course, there are some vaccines that are available for some STIs. The bulk majority of them are not really available, but we have some vaccines for hepatitis A, which is not typically a sexually transmitted infection. It can be transmitted sexually, but it is not. But we have vaccines for hepatitis B. We have vaccines for human papillomavirus infection, which, by the way, is implicated with cervical cancer. Now, let's go into details and look at gonorrhea. So remember that gonorrhea is pretty much caused by Neisseria gonorrhoeae. Now, this Neisseria gonorrhoeae is a gram-negative diplococcus that occurs in humans and is almost always sexually transmitted. So it's transmitted through sexual contact. Now, remember that you may have this infecting areas in the genital system. It may also affect certain mucous membranes depending on however you're acquiring the infection. So you may have urethral and cervical infections, which are very common. You may have pharyngeal and rectal infections, especially if they partake in oral and anal intercourse. You may also have conjunctivitis that may be as a result of contamination of the eye. This is also very common in newborns who are born to mothers who have gonorrhea, active gonorrhea. Then, of course, after an episode of vaginal intercourse, just like with HIV, the transmission is easier from male to female than it is from female to male. So from female to male, it's about 20%, and it's quite higher from male to female. So it's easier to transmit the infection from a male to a female, just like with HIV and we talked about. And like I said, the neonates can acquire a conjunctival infection as they pass through the birth canal, and children may actually acquire gonorrhea also as a result of sexual abuse. So you have to actually evaluate that. In about 10 to 20% of the women, they may get a cervical infection that usually ascends into the endometrium, and eventually affecting the fallopian tubes, causing them to be inflamed, a condition we call salpingitis. It may also result in involvement of the pelvic peritoneum, and this is a disease that we refer to as pelvic inflammatory disease. Now remember that gonorrhea is not the only thing that can cause this. Chlamydia, intestinal bacteria can also cause PID, and remember that gonorrhea cervicitis is commonly accompanied by symptoms like dysuria, which is difficulty in urinating, inflammation of the skin ducts, as well as the Bartholin's glands. Then, of course, in a small fraction of men, the infection may ascend and result in a urethritis that may progress to an epididymitis. In some patients, you may have disseminated gonococcal infection, which is often due to hematogenous spread that occurs in less than 1% of the cases, predominantly in women. And this disseminated infection typically affects the following structures. It can affect the skin, the tendons, the joints, the pericardium, the endocardium, the meninges, and sometimes even the liver. You may have a perihepatitis that may occur, but this is a bit rare. And of course, some co-infections could happen with Chlamydia trachomatis in 15 to 25% of infected heterosexual men and about 35 to 50% of women. Now, what are some of the clinical features if someone gets gonorrhea? So you may have patients being asymptomatic. So 10 to 20% of infected women and very few infected men are asymptomatic, meaning they won't have any symptoms. Then you have 25% of the men having minimal symptoms. So what are some of the presentations? You may have male urethritis. Remember, gonorrhea is a cause of what we refer to as gonococcal urethritis. You have an incubation period of about 2 to 14 days. Remember what incubation period is? The period to which when you acquire the infection to when the symptoms actually manifest. So you may have things like mild discomfort in the urethra that may follow more severe penile tenderness and pain. They may have dysuria, which is this difficulty in urinating. They may have pain on urination, this burning sensation when they urinate. They may also have a pus-like discharge, a purulent discharge. The number of times they go to urinate will also increase. They have urinary frequency, and the urge to urinate will also increase. They'll have urgency. These actually develop if the infection actually spreads to the posterior urethra. Then the examination is going to be revealing a purulent yellowish, greenish urethral discharge. Sometimes the meatus may be inflamed. Then you may also have epididymitis, which is usually going to be resulting in unilateral scrotal pain. You may have tenderness, you may have swelling. Rarely, the individuals can actually develop an abscess of Tyson and the litter glands. You may also have a periurethral abscess. You may have infection of the colpoid glands. You may have infection of the prostate. You may have infection of the seminal vesicles. Then, of course, in women, you're going to be having your cervicitis, which usually has an incubation period that's greater than 10 days. So also here, you may have symptoms varying from mild to severe presentation, but generally they're going to have dysuria, which is your difficulty in urinating and pain on urinating. You may have your vaginal discharge. And then, of course, if they have a pelvic examination, you're going to be noting that there may be a mucopurulent discharge or a purulent cervical discharge. And, of course, the cervical ostium, the opening of the cervix, is going to appear red. It's going to be bleeding easily when it's touched with the speculum. Now remember that urethritis may occur concurrently with other infections. It may occur with, of course, your chlamydia infection, but generally pus may be expressed from the urethra when you actually press on the pubic symphysis or from the skin ducts or the Bartholin glands. Rarely the infection is actually as a result of sexual abuse, especially in prepubertal girls where they're going to have dysuria, purulent vaginal discharge, vulvar irritation. They may have redness or erythema in the area. They may also have edema. Then you may actually complicate into pelvic inflammatory disease, which can actually occur in 10 to 20% of infected women. So it may actually affect the fallopian tube, causing a salpingitis. It may cause a pelvic peritonitis. Sometimes it may result in a pelvic abscess. Now remember that these patients are going to present with low abdominal discomfort. Typically it's bilateral on both sides. Dyspareunia, which is of course pain upon sexual intercourse. You may have marked tenderness on palpation of the abdomen. You may have cervical motion tenderness. You may have tenderness in the adnexae. Then there is a complication that may result involvement of the liver. So we call this as a perihepatitis, gonococcal, or even sometimes chlamydial perihepatitis. It's known as a Fitzhugh-Curtis syndrome. Now remember that this is predominantly seen in women. You're going to get these violin-like strings that you can actually visualize across the surface of the liver when you do a laparoscopy, then of course this is going to result in right upper quadrant abdominal pain. You may have fever, you may have nausea, you may have vomiting, and often this is going to be mimicking either biliary or hepatic disease. In the rectum, especially those that participate in receptive anal intercourse, and this can actually even occur even in women that participate in anal sex, but most commonly it's seen in homosexual men. So here the symptoms are going to include things like rectal itching. There may be a cloudy rectal discharge. You may have bleeding, you may have constipation, and these all have varying severities. When you examine this patient with a proctoscope, you may see that the area is red and has a mucopurulent exudate on the rectal wall. You may sometimes have it affecting the oral cavity. Now remember that, the pharynx rather, you remember that you can actually contract this infection through participating in oral sex. Remember one of the myths that we talked about on the first slide? So this is usually asymptomatic, but it can result in a sore throat. But this is very important that you distinguish Neisseria gonorrhea from Neisseria meningitidis, because Neisseria meningitidis can be found as a normal commensal on the throat. Then you may also have disseminated gonococcal infection, which is also called as an arthritis dermatitis syndrome. So this is, you have bacteremia, then you have these manifestations like fever, migratory pain, or joint swellings, which is your polyarthritis. You may have pustular skin lesions, and in some patients, the pain develops and the tendons actually are going to redden, they're going to swell, especially at the wrist or the ankles. You may get some skin lesions, which are very characteristic on the arms or the legs. I think I put a picture in the next slide. So these are going to be having a red base, and they're going to be small. They're going to be slightly painful, and they are often pustular. Then, of course, genital gonorrhea, the usual source of dissemination of infection may actually be asymptomatic. So they may have a genital gonorrhea that gave them the infection, no symptoms, but they just have these features of dissemination. And remember that this can mimic other disorders, and it can cause things like fever, skin lesions. It may result in polyarthritis, which can be a prodrome of hepatitis B infection, or even can be seen in meningococcemia. So this is one of the differentials to keep in mind. Some of the other disorders like reactive arthritis can also cause genital symptoms. Now remember that you may also have gonococcal septic arthritis, which is a more localized form of the disseminated gonococcal infection, and this is going to resulting in a painful type of arthritis with an effusion, usually affecting one or two joints. And then these are the large joints, the knee, the ankle, or the elbow, and sometimes even a smaller joint at the wrist. Now remember that some patients may present with or have a history of skin lesions of the disseminated gonococcal infection, and the onset is often acute with this gonococcal septic arthritis. So they may have fever, severe joint pain, they may have limitation of movement, and of course the infected joints are going to be swollen and the skin may be warm and red. So here is the skin lesions that you see in disseminated gonococcal infection. As you can see over that, this person has disseminated gonococcal infection. It's very easy to confuse this with, of course, your disseminated, or rather your meningococcemia. Now, how do you make a diagnosis? Like I already said, we get microscopy culture and sensitivity, a gram staining and culture, nucleic acid-based testing. That's pretty much a nucleic acid amplification test. These can be done on the genital, the rectal, or the oral swabs, and they can actually detect both gonorrhea, they can detect chlamydia, and these actually have increasing sensitivity, and these have actually replaced most of the cultures and the microscopies that we often do. But if we do decide to do a microscopy culture and sensitivity, we can do it also on the genital fluid, we can do it on the blood, we can do it on the joint fluids, which you often obtain by aspiration. Now remember that gram stain is sensitive and specific for gonorrhea in men who have a urethral discharge. What you're going to be seeing is you see this gram-negative intracellular diplococci. That's the typical characteristic feature of Neisseria gonorrhea. And remember that the gram stain is much less accurate for infections of the cervix, the pharynx, and the rectum, and it's actually not even recommended for these sites. Then, of course, culture is sensitive and specific, but gonorrhea is actually very difficult, and it's it's fragile. It's very difficult to transport it from the sample that you've collected to the lab. Remember that the samples are taken by a swab, and then they are put on an appropriate medium, which is your modified Thayer-Martin medium. And of course, they're going to be transmitted to the lab with a carbon dioxide containing environment. So we can actually send our blood and joint samples to the lab and notify the lab that we suspect that this is a gonococcal infection. So, but most of the labs actually have been replaced with nucleic acid amplification tests. Now, in men with urethritis, so there's going to be an obvious discharge, so we can actually treat them presumptively if we are unsure of the likelihood, or it's questionable that this patient may return. We may treat them on presumption that this is definitely gonorrhea. Then, of course, samples for gram staining should be obtained by, of course, touching a swab or sliding the end of the penis to collect the discharge. Then, of course, a gram stain does not identify chlamydia, so urine and as well as swab samples should be sent for nucleic acid tests. And then in women that have genital symptoms or signs, you may get a cervical swab, which should be sent for culture. It should be sent for nucleic acid testing. If a pelvic examination is not possible, then a NAT should be done on the urine sample or a self-collected vaginal swab that can detect gonorrhea or chlamydia infections rapidly and reliably. If you're detecting that this person has a pharyngeal or rectal exposure in either sex, whether man or female, then the swabs should be taken from the area. They should be taken for culture. They should be taken for nucleic acid testing. And of course, arthritis, disseminated gonococcal infection, or both. You aspirate from the joint and you send this fluid for culture and routine analysis. So patients who have these skin lesions, systemic symptoms, or both should have their blood, their urethral, their cervical, their rectal cultures done, and you should also perform NAT on these samples. Then, of course, in 30% to 40% of the patients with disseminated infections, blood cultures are usually positive during the first week of the illness. Then in patients with gonococcal arthritis, the blood cultures are actually less positive, but the cultures from the joint fluids are usually positive. And remember that the joint fluid is going to be appearing cloudy. Sometimes it may be purulent, and you get a large number of white blood cells. So typically more than 20,000 cells per microliter. Now, how do we screen for this? So remember that asymptomatic patients should be considered as high risk of getting sexually transmitted infections. These should be screened for a nucleic acid test on the urine samples. And this is actually not really an invasive procedure, and sometimes you don't even require to collect the samples from the genital sites. You just ask the patients to pee in a urine specimen bottle. Then, of course, in the non-pregnant women, including women that have sex with other women, they should be screened annually if they are sexually active and less than 24 years. And if they have a history of a prior sexually transmitted infections, if they engage in higher risk sexual behavior. And what is this? If they have a new sexual partner or multiple sexual partners, or they engage in sex work, or they use condoms inconsistently. If they have a partner who engages in high risky behavior, then they should be screened. Then pregnant women are usually screened during their initial visits of antenatal. I talked about the screening of STIs and HIV in HIV week. And then, of course, this should be done in the third trimester if they are less than 24 years and they have other risk factors. Heterosexual active men are not routinely screened unless they are considered as high risk. So those that have multiple sexual partners, those that have or are rather patients at adolescent on STI clinics, and men that are entering correctional facilities, these are often screened. Then homosexual men should be screened if they are having sexual activities within the previous year. So for insertive intercourse, you should do a urine screen. For receptive intercourse, where you're the one who's receiving, then you should get a rectal swab, and for oral intercourse, a pharyngeal swab. And remember, those with HIV infection, multiple sexual partners, or whose partners have multiple other partners should be screened frequently, so at about 3 to 6 month intervals. And remember that also, do not forget to order for an HIV test, because if they have a sexually transmitted infection, there's a high chance that they may also have contracted HIV. Then how do we manage this? So for the uncomplicated infections, we usually give a single dose of ceftriaxone plus azithromycin. For the disseminated infections with arthritis, we usually use a longer course of parenteral antibiotics. So we treat together with the chlamydia infection, and we make sure that we treat the sexual partners. So here are the dosages. So for the uncomplicated infections that have urethral, cervical, rectal, and pharyngeal infections, the preferred regimen is, of course, a single dose of ceftriaxone. That's 250 milligrams IM intramuscular, plus azithromycin 1 gram orally as a start dose. An alternative is, of course, giving Cefixim 400 milligrams orally, plus azithromycin 1 gram orally. All these are start doses, so you're only giving them once. But if a patient is actually allergic or reacts to azithromycin, or if they immediately vomit, then give them doxycycline 100 milligrams that's taken orally twice a day for 7 days as an alternative. Then for the patients that are allergic to the cephalosporins, these we treat them with, of course, the gemifloxacin 320 milligrams orally plus azithromycin 2 grams orally once. And then, of course, you can give gentamicin 240 milligrams intramuscular injection plus azithromycin 2 grams orally once. And remember that previously we used to give this monotherapy single drugs like fluoroquinolone, ciprofloxacin, levofloxacin, ofloxacin, or even cefixime. This is no longer recommended because there is increasing resistance to the drugs. Then, of course, we should sometimes test for cure. This is recommended for patients who have been treated with an alternative regimen for the pharyngeal infections. Now, those that have disseminated gonococcal arthritis, these should be treated with intramuscular or IV antibiotics, intravenous antibiotics. So your ceftriaxone 1 gram IM or IV every 24 hours. Or you can give ceftizozim, which is 1 gram IV every 8 hours, or cefotaxime 1 gram IV every 8 hours, and this should be continued for about 1 to 2 days. Once the symptoms lessen, then of course you can transition them to the oral therapy that's going to be susceptible to the infection that they have, and at least treat them for at least 7 days. We should also give a single dose of azithromycin as adjuvant therapy for those that have gonococcal infection and possibly a co-infection with Chlamydia trachomatis. Now, gonococcal purulent arthritis usually is going to also require the repetitive draining of the synovial fluid, so you can do this by arthrocentesis or even arthroscopy. So initially the joint is immobilized in a functional position. Then of course you may perform some passive range of motion exercises as soon as the patient can tolerate them. Then once the pain has subsided, then you can go into active exercises with stretching, as well as the muscle strengthening should be also done. And then over 95% of the patients that are treated with gonococcal arthritis actually recover with complete joint function. Now, because the sterile fluid actually accumulates, the effusion in the joint accumulates, there may be develop this persistent prolonged periods, so some anti-inflammatory drugs can be beneficial for these patients. And remember that post-treatment couches are necessary if symptomatic response is adequate. However, if the patient does not respond, so for patients with symptoms for more than 7 days, specimens should be obtained for culture and they should be tested, especially for sensitivity, because you may be giving something that is resistant. Then, of course, patients should abstain from sexual activity until the treatment is completed to avoid infecting the sexual partners or to avoid being reinfected. And remember that there is an increase in drug resistance, so experts no longer recommend monotherapy for gonococcal infection. We usually use more than one drug. Then for the sexual partners, all sexual partners who have had sexual contact with the patient within 60 days should be treated for gonorrhea and other sexually transmitted infections. And if we screen these patients, we should treat them. We test them for gonorrhea or test them for other infections. If we find that they're positive, treat them. Then, of course, for the sexual partners with contact within 2 weeks, we just assume that they have the gonorrhea, so we treat them. We call this as epidemiological treatment. Then there is something that's known as expedient partner therapy. So this expedient partner therapy is pretty much giving the patient a prescription or even the drugs to give their partner. We want to trust the patient. So this expedient partner therapy is going to be enhancing the partner adherence, and it also reduces the treatment failure, because if you're treating both of them at the same time, chances of reinfection are less. It may be most appropriate for partners of women with gonorrhea or chlamydia, because sometimes it's very difficult to get the husbands to come to the hospital. So a healthcare visit is preferable to ascertain histories of drug allergies as well as to screen for other STIs. But in a case where the patient actually refuses or the partner refuses to come to the hospital, this is the best that you can actually do. Here's our warm-up question, which is a single best answer. Pelvic inflammatory disease, a term that is a term used to describe infection in a pregnant woman in first and second trimester. No, this is very vague, and it's actually not really correct, because even non-pregnant women do get PID. And of course, can be sexually transmitted. It can. Is not common in young women. It is, especially those that are sexually active. Has no bearing on fertility. So this is actually one of the causes of infertility, because a patient can actually complicate in having what is referred to as a tubo-ovarian abscess. I really hope you enjoyed this lecture on gonorrhea. If you did, consider subscribing to the channel, hit the bell notification icon so that you never miss any of this amazing content. Drop a like, drop a comment to Zambia and beyond. My name is Dr. Moses Kazevu. Until next time, bye-bye.